Hello there. Good evening, everybody. Thank you so much for joining our Teoxane Wednesday monthly webinar. So good to see everybody here. I see some familiar names amongst the attendees. Hi, Andy, Dr. Ida, Dr. Fong, Noor, Dom. Thank you so much for joining our webinar call today. So we're really excited for the webinar session that we have today, which is the part 3 of our webinar series on eye rejuvenation. And today is a really unique session, which I will bring you up to speed shortly. So as you know, we are very passionate about the eye area because the eye area's anatomy is rather complex compared to the rest of the face. It requires skills and also a high sensitivity towards the safety in terms of the treating this area. So Teoxane, we are very excited to do this, to bring you up to speed with this 3-series webinar that we have so far on eye. So today we'll focus a lot on the local expert masterclass and also latest updates in dermal visual loss. I would like to take the opportunity to introduce our 3 panelists for our session today. First up will be Dr. Fong. Dr. Fong is a plastic surgeon from Vietnam. So she is the medical trainer for Teoxane, our country expert, as well as the medical director for Grassroots. Dr. Fong is very well experienced plastic surgeon, and she's highly passionate about aesthetic and dermatology. So she conducts training very, very regularly in Vietnam, and I know that she has a lot of passion for the industry, and she's also a highly engaging trainer. So we are very happy to have her here with us today. And then I would like to introduce our next speaker, Dr. Henry. Dr. Henry needs no further introduction. He's his face is highly familiar in our region. He is the medical director and also owner for Millennia Aesthetic Dermatology Clinic. He's a certified dermatologist, as well as also completed his clinical fellowship in the Department of Plastic and Reconstructive Surgery in GK Medical University in Tokyo. And then last but not least, Dr. Tahera Bhojani-Lynch. Dr. Tahera has been leading our webinar series so far on the eye, and I'm so honored to be able to have the opportunity to work with her on many occasions this year. Personally, she is a very personal clinician, and she's also a very humble doctor. Dr. Tahera is a very accomplished clinician, both professionally as well as personally. She's a mother of 2 boys, and I know that they are absolutely gems in her eyes. And to add to her accreditation, she is a eye surgeon by training. She resides in the UK. She's an ophthalmologist, and to add to that list, she also has a postgraduate in diploma in dermatology, cosmetic science, laser skin therapy, and she has been, in her 20 years of clinical practice, she has been involved in clinical research involving hyaluronic acid products for injection and also botulinum toxin. So hey there, Dr. Tahera. Okay, so we have the chat box here open. So if you have any comments and any questions as we go through our session today, do feel free to pop your comments, ask questions, give us feedback in the chat box. We'll love to hear from you. So just to run you through what we'll be discussing today, in context, we have engaged with our country experts who are highly passionate about injecting the eye area and treating the eye area a few months ago. We have invited them, Dr. Henry and Dr. Fong, to collaborate with us to do a case collection and to also for using Redensity 2 to treat the eye area and share with us their injection techniques, as well as what is their thought process as they engage with the patients, and what is their clinical assessment, and how do they approach the cases and also they will be sharing with us their injection technique through video in the call today. So Dr. Fong will be sharing the cases, and also Dr. Henry. First of all, let's have Dr. Fong to share her case. Dr. Fong, are you there, and are you ready?
Yeah, I'm there. Thank you, Nadia.
Okay, to you, Dr.
I will
Fong.
share, I will share my screen now. Yeah, can you see my screen?
Yes.
Okay. Okay. Yeah, thank you, Nadia. And I'm Dr. Phương from Vietnam. And today I will sharing for you about the my experience about the periorbital treatment for the Asian patient. My presentation have 4 parts. At part 1, I will introduce the ATP approach. Part 2 and part 3, I will sharing my case study. And part 4, I will give some take-home message. As you know, ATP is a concept that can help you to understand everything before you inject for the patient. A are anatomy and assessment, T is technique, and P is product. You can before you can inject for the patient with the safety, we need to understand deeply about the anatomy and assessment, and the technique we choose, and the best product we use for the patients. And I always ask my patient expectation and what do they want to treat. And after that, I discuss with them which is the best procedure I will do for them. So now we can move to case number 1 of mine. This is the female patient. She's 27 years old, and we can see the before picture of her. In the anterior view, you can see she has a tear trough, a dark eye circle, and she lost a volume in the medial cheek and medial sheath and the medial cheek fat compartment. And the lateral and 45-degree view, you can see the negative vector of the teardrop in there, and she lost a volume in the medial sheath and the cheek fat compartment. And my treatment plan for her is I will do the mid-cheek first with arch at a 3. In the step 1, I inject into the bone. I blush onto the bone 0.2 cc per point. Step 2, I will blush onto the bone 0.1 cc per point. And to point of that, I will support for the medial sheath. And step 3, I use the cannula to inject for the medial cheek fat compartment 0.2 cc per side. And after that, I will treat in the eyes area with the redensity tool. You can see in the tear trough, I use the cannula to inject 0.35 cc per side, and I inject onto the bone in the lateral sheath 0.15 cc per side. And you can see before and after picture of her. And total volume I use for her in this case are 1 cc arch A3 and 1 cc redensity 2. And in the 45-degree view, you can see the midface has a beautiful contouring after injection in there, and the tear trough is more brightened and more smoother, and the wrinkle is reduced. Yeah, this is the before and after picture of her. Let's move to case number 2. He's a male patient, and he's 22 years old. And in the anterior view, you can see he has the tear trough, the mid-cheek fold, and he lost a volume in the deep medial cheek fat and medial sheath orbicularis oculi fat. And in the lateral and 45 view, you can see the tear trough, the midcheek fold, and the loss of the volume in the deep medial cheek fat and end sheath. And you can see the negative vector of the tear trough. And you can see my treatment plan for him through the video. First, I draw the line, the vertical line, and the tear trough line, and the midcheek fold. And after that, I mark the point I will inject with the needle in the midcheek fold. After I mark, I use a little bit of lidocaine in the entry point to reduce the pain for my patient. And after that, I start to treat the midcheek fold first with the needle. I inject onto the bone. Before I inject, I always make sure the tip of my the tip of the needle touch to the bone, and I inject slowly with a small volume and lower pressure. And I always check my feeling of my patient. If he feel pain, I will check again, and I'm just do it when he not feel any pain anymore. Sometimes I usually aspirate while I'm inject to make sure I'm not going to the vessel. After I inject, I use the cannula to treat the medial cheek fat. The left hand side usually, I usually use the left hand side to check the tip of the cannula to make sure where my tip of cannula is and how depth of the cannula of mine. The next step, I treat for the lateral sheath with the needle, and the last step, I treat the tear trough with the cannula. I make a hole, and my cannula go deep onto the bone, and after that, I change the angle of the cannula, go to the tear trough. It can help me to make sure that my cannula is deep in contact with the periosteum. And after I inject, I use the Teoxane boss procedure to massage for my patient in the end of section. You can see the before and after of this case, and you can look again my treatment plan. Step 1, I polish onto the bone 0.3 cc per point. Step 2, I inject with the cannula in the medial cheek fat compartment, 0.6 cc per in the right side and 0.25 cc in the left side. And in the eye area, I use the redensity tool. I inject onto the bone in the lateral sheath, 0.2 cc per point. And step 2, I inject with the cannula with the tear trough. In the tear trough, 0.3 cc per side. And this is the result. And total volume I use for him is 2.05 cc RHA4 and 1 cc redensity 2. And this is the result of 45 degree view. Yeah, you can see the result of this. And my last part is a take-home message. For me, I always do the safety first, and I always inject with small volume and lower pressure. And I always do under correct is for my patient, because I think 80% of the result is the best choice for the first section. And between male and female patient, I have different of approach, and choosing the type of filler HSA is very important to make my result is beauty and more natural. Thank you.
Amazing. Thank you so much, Dr. Fong, for sharing your injection skill and also your technique. I think particularly the male patient was not an easy case. Definitely can see the results. And also your photos also included the photos of the patient with the expression. So we can definitely see very natural results from there, particularly during the video. So I'm sure we'll open the floor for a discussion on Dr. Fong's case shortly. But if you have any questions, do feel free to put it in the chat or the Q&A section. And before we discuss further into Dr. Fong's case together with Dr. Tahera, let's have Dr. Henry up next, who will be presenting his cases as well. Dr. Henry, are you ready?
Yes, so ready with in my pitch now. I'm leaving. Okay, so let me share my screen first. Hi, I'm Dr. Henry. Yeah, I'm so seeing some familiar names on the list, and I'm so happy also to see some Thailand doctor's name, although I don't know them, but hi from Indonesia for Thailand doctor. Welcome to Teoxane family. So yeah, this is my presentation for today. So I'm sharing my personal experience in the tetraf injection area. So yeah, this is my patients that I present for today. So she's Miss F, 36 years old. Yeah, like most of the 30 plus years old patients usually complains of the having tired looks or like a sleepless nights on the face. And she came and asked for the treatment. Then this is the blessing of our Asian skin that have relatively thick skin, especially in the subcutaneous layers. And I feel that she lacks of some light anterior projection in the mid-face as well. And I see some deep fat deficiency on the anterior part for her. And we are all agree that we are trying to avoid the lateral volumizations, especially in the Asian face. So we don't do the lateral expansion or lateral whitening in the Asian face. And for her, I choose, this is quite unique because as we all know that the RC3 is not the indication for the deep layer injections. But for her, I choose the usage of the RC3 deep in the deep fat layer and the superficial layer, combining with the redensity too. And I'm choosing the RSA3 because I only want to give her a soft fill effect, not offer volumizations, especially on her anterior area of the mid face. And for the density too, we all know that this is a very special filler designed for the periorbital area. So this is her before, and this is her after 3 weeks the injection done for her. Sorry. So this is the before, and this is the after the 3 weeks injections. And I have the zoom versions. This is her before, as you can see here, her tetraf, the under eyes area before, and this is after 3 weeks. And we can see a lot of improvements. And you can see also not only the shadow from the tetraf that getting better, but also the skin quality around the tetraf. This is commonly seen in my redensity 2 patients because redensity 2 fillers also have some bonuses that make the skin quality around the periorbitals becomes better. This is not the lighting effect because I use a standardized camera to capture this image. And you can see from the anterior photo as well, this is her before and this is her after. So you can see all over your face, there is no change, including the pimples you can see on her forehead. But when you see on the inferior eyes, you can see how better her inferior or under eyes becomes after 3 weeks of the injections. This is the power of the Teoxane products, combinations between the RC3 and the redensity 2, just only single usage, single treatment, 1 syringe every product, RC3 1 syringe and redensity 2 1 syringe. So how I do the treatment, this is my secret recipe that I want to share with you all for this afternoon. So you can see in here, I always start with the deep layer first. As you all see, the orange syringe means the RC3, and I decide to divide the products 1 cc, half syringe for the left part and half syringe for the another part. And I also ask my patients to look up to see where the deformity that she have. So I will fill that then more in the deep layer with the products. I can choose actually the RC4, but I choose the RC3 in her case just to give a very soft amount of filling effect. And you know, RC3 in the Teoxane range of the RC series is balanced products that have a good projection, a good dynamic level, and also for the projection and also the dynamic filler. So it's not as strong as the RC4, but it's not as weak as the RC2. So I put the products in the deep layer in the medial cheek fat compartment, and then coming from the same entry points. And one important thing is when you poke your needle in the patient's skin for the entry points, go deep. So your cannula will go directly in the deep layer on the bone. So it will easily give you the access to get into the deep layers. And then from the same entry points, I go to the superficial medial cheek fat compartment where I want to fill and give the anterior projection for her. So giving the new light reflections on her cheeks. So it will looks nice when she's smiling or when she's giving her expressions. And then I do in the same patients for her left part, sorry, on the right part. This is, I do the same thing on her filler on the right cheek. During the filler injections, I tend to finish one area first with the same products. So I can estimate the uses of the products that need to be used for the patients. So in this case, I spend the rest of the RC3 first. And if I feel that the RC3 is not sufficient on the left part, then I will fill the left part with the same product first. And you can see in here, because the dynamic fillers also needs the dynamic feeling way. So always ask the patients to look up, smile, or sometimes ask the patients, have a chit chat with the patient so you can see whether your filler is positioned in the correct way or correct location or not. And I spread the gels all over the superficial layers and deep layer also with the RC3 in the targeted area. And I always love to use the cannula because I can spread the gel better than the needle. But sometimes I also use the uses of the needle to fill some area in my patients. And then, of course, the next step that I choose is to fill the T-trough area with the Radiant CT2. Radiant CT2 is one of the most important products, and it is the only one product that is the market that designed for the periorbital area. You can use the needle or cannula to fill the T-trough with this product actually, but for her, I prefer to use the cannula, and I use the same entry points. I always go deep, like the seam that I provide in the first picture up. So you can see that my cannula is filling the soothe, but my cannula is actually reaching to the bone layers in the periosteum layers. So I'm not going superficial, although this product sometimes is quite forgiving, but please stay on the deep layer to when you're filling the T-trough. And I never feel the medial part because I think that medial part is very loose, and when we are trying to fill the medial part, we can get some sausages after years. Hence, I do these special tricks that I I subsize my patients in the medial part with the cannula in the subcutaneous layer. So you can see in here when I'm filling the deep part with the Radiant CT2, I spread the gel from the medial part to the lateral part, including the extra lateral one. Then you can see in here my cannula going very superficial, not to fill, but just to subsize the subcutaneous layer of my patients in here. So I use the same products, the same cannula to fill on the opposite side. Here you can see better when I'm doing the subcisions for my patients. This is the right T-trough. I'm filling on the deep layers on the bone of my patient, spreading the gel coming from the medial part to the lateral part. Okay, and then you can see in here, after I think that is quite enough, then I feel the medial, the inferior of the teeth trough in the subcutaneous sometimes, feeling the medial part, the medial cheek fat compartment sometimes. And then I also subcise the subcutaneous layer between the teeth trough, superior and the inferior also. So this is will giving like the decreasing the crease of the patients, and also going to the medial part of the teeth trough like this one. You can see I try to zoom the video, going very superficial, and I subcise that area. So this is the take-home message from me. So you can see the video. She's very surprised with the result. I give her the mirror. She looks pretty immediately. She comment for that one. And she's very happy with the results. She looks very younger. Wow, several times. Oh my God, several times. So it's very important to have a good patient. The patient selection is the key. If not a filler case, then please refer the patients to the surgeon or any other treatments. ATP is the key for the result for in Teoxane way, the anatomy, technique, and the products. And for me, I always go deep because the subcutaneous layer for the Asian patients usually is quite thick, that we need only to fill a bit in the superficial layers, and less is always more if you choose the correct amount in the correct selection of the product in a correct positions of the product. And don't forget, because this is the dynamic fillers specifically designed and the only one that approved by the FDA, the dynamic range of fillers product with the RC series. So always examine your patient in the static and dynamic positions. And I always fill my patient in a static and a dynamic fashions. And don't forget the blessing of the ethnicity from the gut. Preserve the ethnicity and the natural look of your patients. Okay, I think that's my presentations. Thank you.
Amazing. Thank you so much, Dr. Henry, for sharing your before and after, and also video injection video techniques. Very, very nice. And very good tips for the secret recipe. You'll definitely take note of your recipe. So now I would like to have an opportunity for us to discuss and also go through some Q&A for the cases that was shared by Dr. Fong and also Dr. Henry. Dr. Tahera, are you there?
I'm here. Wow. That was a masterclass if ever I saw. Male patients, young patients, very small defects, beautifully corrected. Well done, guys. Well done.
So maybe we can start by addressing some of the Q&As, and then we can hop on to some of the discussion points.
Can I ask a question before you go to the audience? I've got a question for Dr. Fung. I was really actually interested because she did two cases, two very different cases. And you chose Redensity 2 for the under eye in both. On the female patient, you chose RHA 3. On the male patient, I think you used... was it RHA 4?
RHA 4, yeah.
On the male,
RHA 4.
Yeah. So just talk me through your product choice for the mid-face on the male and the female. Was it because they were male and female? Did you have some other thought? And why for both of them you used Redensity 2?
Yeah, okay. I choose the different RHA in the mid face because I will focus on some reason. Firstly, the age of the age of the face, the thickness of the skin layer, and the volume loss of the fat tissue, and the rheology of this product. But you can see both of my cases is very young, so I'm just focused on the thickness of the skin layer and the rheology of the RHA4 and RHA3. You can see in the the male patient, the skin is thicker than the female, and so I need to increase the volume. But I don't want to I don't want to make my male patient look static and frozen. So I choose the product have a very high strength. It's the RHA4, and of the female patient, she has a thin skin and she lost a volume in the medial sheath, and I need to fill off, and I don't want to make her have a puffy face. And so I will choose the high strength and good strength for is the RHA3. And the between though of the RHA, they have a very long chain HA and high molecular weight, and they have a low cross-link, and they have the dynamic network, so they can have the result is after injection is very dynamic, without looking stiff or unnatural. Yeah.
You know, I like how you've tailored the rheology of the product with the end result in mind. You know, you're looking at where it's going to be after you've injected. I always say that it's very easy to teach somebody how to put a needle in the skin and press the plunger. You can actually teach anybody how to do that. Anticipating what's going to happen when you press the plunger and what the product is going to do comes from a bit of knowledge. And you've just demonstrated how well you understand these fantastic products that work differently in different parts of the face. It's nice to hear. Dr. Henry, can I ask you something? I liked seeing your subcision technique.
Thank you.
You took the cannula and you ran it under the skin. So I have seen people subcise deep and subcise superficially, alleging that both will give you similar effects. Tell me why you choose to subcise superficially.
Yeah, I like to give some release from the subcutaneous attachment from my patients. I'm not subcising deep. I believe when we are subcision in the deep layer, then I can see the superficial effect from my patients. That's why I'm always going superficial. I'm not feeling, but sometimes I can also, there's another trick and secret recipe with the RD1. So with putting some RD1 in a cannula and giving a bit amount of the RD1 when you're doing the subcisions also quite well in releasing the skin attachment for the patients. I think I see in a clinical way.
Do you know, I think you're right on two counts there. When we attempt to subcise deep, bear in mind ligaments are attached to bone. So if you subcise with a blunt instrument, good luck trying to get the ligament unattached from the bone. As surgeons, we know you want to take a ligament off a bone, you need a scalpel to do that. So, but skin attachment to superficial muscle is quite easily broken up, especially if you've got a little bit of lidocaine in a product. The patient doesn't feel the discomfort. Often you get a little bit of edema. So they see an instant improvement. And if you put a little bit of RD1, it delays the healing of it. So then when it heals less attached. So there are lots of very good clinical reasons for doing that just under the skin. And if you put that tiny bit of redensity one in there, you actually see the improvement in the skin and a delay of that reattachment and a smoother reattachment. So I think you've ticked every box there, again, by understanding the anatomy, that ATP showing why, as Teoxane as a company, likes to make sure all of those things are covered. Do we have any questions from the floor, Nadia, or are we going to wait till the end for those?
Yes, we do. We have total of 5 questions. So let's address them, some of them first, and then we'll hop on to the next segment of our webinar today, and we'll try to address all of them later. Okay, so one of the questions that we have is, okay, how does a positive vector affect your approach to periorbital rejuvenation?
Who wants to answer that? Do you want me to answer it? So, looking at the vector of the face has some influence. If you have a negative vector, there is a groove that you can fill. If you have a positive vector, it becomes harder to judge where you're going to put the product and how much lift you're going to get. For sure, if somebody has a positive vector, either from fluid or from fat, you need to be very careful. If someone has a positive vector just from loose skin, it may still be possible to put some support under the skin and give correction, because the idea is that you've got this sort of baggy bit of skin, and if you tighten around the skin, not under the skin, you can actually, so if you've got a positive vector here of skin, and if you do this and it improves, you know that putting filler here, deep, supporting, will actually improve here. Remember, some of the evolution of your tear trough comes from the downward and inward rotation of the skin. So if you've got downward and inward rotation and you've got a positive vector here, you can correct here and improve it. Remember, whenever you're looking at positive vector or negative vector here, first you look at the midface. Can you correct the midface to make this look better? That is always, always your first point of call.
I'm agree with Dr. Tahera. Can we have some interactive way? So to create a very beautiful face, we have to balance between to add or to remove the volume. So over volumizations, of course, will make the face bigger and not looking natural in many ways. So in positive factor patients, not only the modalities are not only the fillers, then we have to choose another modalities to create harmonizations in in a patient's face.
And remember, the face is the whole thing. You can't just look at one part of the face. We were doing a masterclass yesterday in London with really for periorbital rejuvenation, and we had a patient come in with a very wide face. And the question was, how do we take away from the width of the face? And actually, all we did for this female patient, she was very wide here, we gave her some anterior projection, and immediately we no longer noticed how wide she was here, because, you know, they were talking about, do we put toxin in her masseter? They were talking about, how do we take away from the fact that she looks big here? The answer is, bring her forward here. Look at the whole face in every direction, not just from the front. Because as soon as she looked like this, by giving her anterior projection, her whole face changed. Right? She kept thinking she needed toxin in her masseter, but she was so flat here that as soon as we did this, everything fell into proportion. So 3D, the whole face. Don't just look at one bit.
Yes.
I think we're probably running out of time for this section. I don't know how are we doing now, dear?
Okay, so yes, you're right. So we are apologies, we're running out of time for the Q&A section, but we still have another opportunity to answer the Q&A for during the end of the webinar. Let's hop on to the next section where we review some of the poll questions. So as you know, Teoxane Asia, we have our own IG handle, which is Teoxane Asia. Do find us on Instagram. If I can have the poll questions up. Okay, so last week, to help us to prepare for this webinar better and also to understand more of the questions or the some of the concerns our APAC audience have, we actually popped up some questions on our IG handle, and these are the results that we would like to share with you today. And Dr. Tahera, we will discuss and go through some of the questions. So there are a total of 6 poll questions that we shared on our IG handle. So the first is, which of the areas of the face has the lowest risk for visual loss associated with dermal filler administration? So if I can go through the results. So most of the participants, when they answered, they felt that the lowest risk area is actually the under eye, followed by the nasolabial fold, followed by the glabella and the nose. So meaning the area for the highest risk, most of the voters answered that it is the nose. So may I know, Dr. Tahera, what is your thought on this response?
So I think Asia have pretty much got it spot on. Okay, so the lowest risk by far is the tear trough area, which is interesting, isn't it? Because we hear that people are quite scared of treating tear troughs because they're worried about the risks. And I think in reality, the true risk of the under eye area is not visual loss. The true risk of the under eye area is poor cosmetic outcome. So we worry about the poor cosmetic outcome because if it doesn't look good, it looks really bad. Yeah, puffy eyes, when you get it wrong, it's not a forgiving area. And people confuse poor aesthetic outcome, which is actually quite easy to resolve if you know what you're doing, with visual loss, which is a completely different set of circumstances. And of course, high risk areas are the nose, nasolabial fold, this central area. We know vessels, tracking to the sinus, cavernous sinus. When you have infection in this area, we think about cavernous sinus problems. When you get injection in this area, we think about vascular events. It is a higher risk area. So Asia, well done.
Thank you. Thank you. So if I can have the next question up. Okay, so our question to you, our IG followers, is how frequently do you encounter your patients expressing concerns about visual loss associated with dermal fillers in the under eye area? So interestingly, an equal number of responses gave rarely, which is 40%, and also equal number of responses gave frequently. So that's quite contradicting and ironic, if I may say. So 40% as well.
So interesting. I think practitioners are more aware of the potential of visual loss. Certainly in the European side, it's not a question we often get asked. In fact, if we volunteer it as a potential side effect, people are, what, you can lose your sight with a filler? Especially in the UK, where there are relatively unqualified people injecting, the idea that something with such a serious side effect is let loose on people who have no knowledge of anatomy, patients find that quite surprising. I suspect the answers, because you're going across the whole of Asia, I suspect there will be more knowledge, patient knowledge. Remember, most people get their knowledge from social media. So it is whatever's trending in your country. So the discrepancy is probably because you're in different countries with different bits of social media being pumped at you.
Yes, I agree. That probably makes sense. So to our next question, the third out of 6. So which precautionary measures do you prioritize when administrating or injecting dermal fillers to minimize the risk of visual loss? So going from highest to lowest, okay, so the highest is the injection depth and technique. The second is use of cannulas instead of needles. And then the last two, which are same in percentage, is aspiration before injection, as well as proper patient selection and assessment. Dr. Tahera, what are your thoughts in terms of for your practice? What is the measures that you think is the most important when you administer dermal fillers?
So knowledge of anatomy is going to be your single biggest way of avoiding complications. And that's knowing where you're going to put it, the depth, and the technique you're going to use. So for those, again, I think Asia are really hot on safety. I think as a group of practitioners, safety comes high on your list of priorities. It is a credit to you that you know that it's all about technique and depth. Technique and depth, technique and depth, okay? Cannula versus needle is partly a technique, but bear in mind, there are some places on the face that a cannula is more dangerous, and some places on a face where a needle is more dangerous, and some places on a face where a cannula is safer, and some places on a face where a needle is safer. And there are some places where it doesn't make a difference. The depth is all that matters. So I understand why people say cannula versus needle, but don't think cannula equals safe, and don't think needle equals dangerous, and don't think the other way around either. Okay, anatomy and depth are more important. Okay. Aspiration, if you read any technical papers on the evidence with aspiration, you'll find that there is very little supportive evidence. And if you're a believer in evidence-based medicine, over time you will probably move away from aspiration and just concentrate on technique and depth. Patient selection, of course, is important, but patient selection is more important about outcome than it is about safety, I think. You select your patients well, they'll get a good result. Your safety should be the same whether you've got an old patient or a young patient, a slim patient or a chubby patient. Your safety should be the same. your outcomes may be slightly different.
Got it. So very much you're in agreement with most of the poll responses, which is the injection depth and technique.
Absolutely.
Okay, let's hop on to the next one. Okay, in your opinion, how often should practitioners or doctors or injectors discuss the risk of visual loss with dermal fillers with patients who are considering dermal filler treatment? The most common answer is in between, always, regardless of patient's concerns, and only if the patients ask about it. So it's in between.
So again, I
Tricky
think these may be regional differences and fear differences. In the UK, we are obliged on our written consent to advise patients of even very rare complications if they are particularly devastating. Of course, visual loss is particularly devastating. So even if there had only ever been one case in the whole of the world, once it was published, we would be obliged to put that in our consent form, because that's a medical legal requirement in the UK. In other countries, it may not be so great, but ultimately, I think it is ethical to advise your patients, but maybe in a nice way. You know, these are very rare events, very rare events. Therefore, making it the most important thing you discuss with the patient, much more important to talk about poor outcomes, hyaluronidase use, you know, asymmetry, lumps and bumps, swelling, bruising, the common side effects. But in the rare things, you know, late onset inflammatory response, visual loss, they have to be mentioned. How you choose to mention them is up to you. You may not want to vocalize it. You may just want to put it in the consent form and make sure it's read. But, and again, I think in the UK, it'll be very similar to this. Some people will only mention it if they're asked, but most of us would mention it regardless.
Okay. So good clinical practice, and also depending on the practitioner's preference, but okay. So the next question. Okay, this is the second last poll question that we popped in our social media. How confident do you feel in your ability to properly assess visual loss following dermal filler injections? So there is a tie again. 44% answered moderately confident, and then 44% also answered slightly confident, whereas only 11 and 0% answered very, very confident or not confident at all.
So this is interesting, isn't it? I think if you ask this question in the UK, there would be far less confidence. I think one of the good things about Asia, we mentioned it, is most of the practitioners are medically qualified. And you would expect them to be able to assess visual loss with a degree of competence. Plus, if you are keeping up to date with your skills, which, you know, it's a credit that there are, you know, a couple of hundred people plus listening to this because they are interested and invested in patient safety. Okay, so I think from that perspective, the fact that most people have got a good idea of what they're doing is a good reflection on your audience. But we will, for those that are less confident, we're going to talk about visual loss in a few minutes.
Yes, that's right. So last question. So do you believe that there is a need for further training and education on managing complications, including visual loss associated with dermal filler treatments? Wow. Okay. So we got 100% response, which was yes, for sure. So we're happy that everybody is very interested, not only on learning the techniques, but also how to manage complications and also visual loss.
So I think that the nice thing about Teoxane is that we listen to what our customers want. It's one of the reasons I've worked with Teoxane for almost 20 years. We are about to talk about visual loss in great detail. At the end of this, you'll all tick very confident, I'm sure. And going forward, if, you know, all of this sort of training, complications training, I think on the back of this, we're going to have a 4th webinar just about complications. So next month, if you tune in, you'll see not just visual loss, we'll talk about the whole range of complications. But if you want more training, you know, Teoxane invest heavily in you as practitioners. I've been part of that journey for the last almost 20 years. You know, if you just contact the APAC events at teoxane.com website, you will be put in touch with your local training coordinators, your local distributors who will be running training. You can put yourself on that steep learning curve to get to the best you can be.
Yes, that's right. So, as I mentioned earlier, this is the third part of our Behind Those Bright Eyes webinar. And in the first and the second Behind Those Bright Eyes session, we have actually covered the Teoxane approach to how to manage eye rejuvenation, what are the danger zones, the different techniques for rejuvenating the eye, including direct and indirect techniques, approaches. Dr. Tahera has shared with us some of the cases that she has done and how she approached the cases and also her injection videos. And in the second webinar, we shared about treatment for the upper face, the temple, how to do eyebrow lift, and why she chooses Teoxane products and the science and the rheology behind the products that she chooses. And today, she'll be sharing with us about a highly controversial topic that some companies or companies might not talk about, but visual loss is associated with dermal filler treatment is something real. It is a rare, but it's also a highly serious topic. So we're really happy to have Dr. Tahera, who also does aesthetic treatment on top of being an eye surgeon, to share with us what are the latest updates on this segment of the adverse event associated with dermal fillers, which is that of visual loss. So to you, Dr. Tahera.
Okay, let me just get my screen up. So sorry, just get my full screen going. Okay, can you see me okay, Nadia?
Yes, looking good.
Excellent. Perfect. So we're going to talk about the terrifying never event, diagnosing and treating visual loss caused by dermal filler. I've done a little bit of research, the most up-to-date set of guidelines I have. Remember that I am an ophthalmologist. I spent most of my career working in eye casualty. So we are used to seeing patients arrive with visual loss, not from dermal filler, but sudden onset loss of vision. So there are protocols already in place worldwide on how to treat sudden onset loss of vision. And to how we as ophthalmologists are adapting these to work with patients who have who have dermal filler loss of vision, and how you as practitioners can implement some of these in your own practice to be safe and effective in diagnosing and treating. So let's start with, if you inject into a vessel, what actually is happening and what will you see? So how would you even know that you've injected into a vessel? So if you get an intra-arterial injection of filler, remember, arterial blood flow is fast. If you put product within an artery, within seconds the product has moved to the end tissue. So your face, you have arterial supply to the skin of your face. If you inject into artery, you will see cutaneous blanching distal from your entry point. So if you inject here, you're going to get white of the skin further away from where you injected, because the product is embolizing through the artery to the arterioles to the capillaries, and the skin will blanch in the area that is affected. So intra-arterial injection produces emboli to the end organ, which would give you cutaneous blanching. If you inject into a vein, it is slightly different, because venous blood is not under pressure moving quickly. And often if you get blockage of a vein, In the short term, sometimes you just get venous stasis. Okay, so you see the blood, you know, you often see that on a varicose vein, you just see swelling and distension of the vein. So this is actually a picture of an intravenous cannulated filler. And you can see immediately there is a distension of the vein, and you get pouring of blood from the entry because the blood is stacked up. Okay, so if you go into a vessel, the visual it looks different for arteries and veins. Bearing in mind, if you go into an artery and you don't get cutaneous blanching because you're in a deep artery, you may not see anything on the surface. If what I've said to you is real and true, so if the blood vessel you inject gives you cutaneous blanching, because that's where the artery is feeding, how is it that when we are injecting the skin of the face, that somehow we end up with filler in the eye? Because if the product is traveling in the direction of blood flow, how could it possibly end up in a different direction? Well, if you think about your blood flow to your face, you have your common carotid artery coming up here, and it splits, and you get external carotid artery supplying your face, and internal carotid artery supplying the internal structures and your brain. But of course, there are some areas of anastomosis, of mixture of arterial blood between external and internal carotid. So there are some in your middle meningeal brain, part of your brain, you can see these little areas of anastomosis. There is an area of anastomosis even in your ophthalmic artery, near your ophthalmic, but actually they're quite far in, and it doesn't really make a lot of sense that it's the anastomosis that makes the difference. What there is also is a small area on your face that has direct supply from your internal carotid artery. So most of your face is supplied by external carotid, but a little, you can almost see where I'm going to point, because that's where external carotid comes. But where does internal carotid? Your internal carotid has 3 branches that supply this part of your face. That's directly from internal carotid. And those 3 arteries are supratrochlear, supraorbital, dorsal nasal. So these arteries are actually end arteries from your internal carotid supply. So there, suddenly now you know which are the most dangerous areas of the face. Okay, this and this. So if you end up putting filler in this part of the face, you've got a shortcut to your ophthalmic artery. But remember, they're still supplying the skin. They're not supplying the inside of the eye. So how does it happen that you end up injecting what should be a supply to the skin, and it ends up going the wrong way down a one-way street? It's going backwards. So if you inject straight into an artery in a dangerous area, there is a possibility of 2 outcomes. Either you just get cutaneous infarction, so that emboli travel in the direction of blood flow and only the skin is affected. Or you get cutaneous and infarction in the ophthalmic artery or within the internal carotid circulation, including you could end up with the CVA, or you could end up with potential visual loss. So you could end up giving a patient a stroke if you put enough of the product going the wrong way, because you get anterograde and retrograde emboli. So 2 possible outcomes, even with an arterial injection, even in the wrong place, that you might just get some skin damage, or you might actually devastate their vision. what would make the difference? How could you reduce that risk if you were unlucky enough to get into an artery? How can you make sure that it's only the skin that's affected and not the vision? So these are the kind of potential risk factors. Of course, getting into the artery in the first place is all about depth, knowing your anatomy. Of course, the direction in which your needle or cannula are going will make a difference. So if you are injecting a nose and you run a cannula in the direction of the blood vessel and the cannula goes into the blood vessel, once you're in that blood vessel, it's going to be difficult to get out. And if you then inject, the direction of your entry point is going to have a direct effect on how much and how hard that pressure is and where that product is going to go. So actually the direction of your needle or cannula is as important as the depth. If you know that the blood vessels are running in a particular direction, you should try and enter at 90 degrees to it. So you're less likely to be carried by the vessel. That slide I showed you right at the beginning, where there was a venous cannulation of a blood vessel, that was one of my own patients, and I literally cannulated the vessel because the direction of my cannula ran exactly in the direction of the superficial vein. It was a mistake made from ignorance of not thinking about the surface veins. Okay, we were able to manage it very successfully with no long-term problems at all. And because you could see the vein, it was very easy to treat. If you see a big distended vein, sticking hyaluronidase in a big distance, you can't miss that target. Okay. But direction suddenly becomes very important when you realize that these are the potentials. The quantity of product you put in will make a difference, because the more you put in, the more potential emboli you're going to get. So I loved what Dr. Dong said earlier, that when she is injecting, she uses small volumes. She specifically said that. And the other thing she mentioned was low pressure, because she's a clever girl. Force of injection, overcoming your systolic blood pressure, will make the difference between whether the product just gets carried with the blood or whether it will go backwards. If you press hard, you can overcome the systolic pressure. If you press gently, the product will go in the direction of blood flow if you are already in a vessel. Okay. And of course, the longer and bigger your needle, the more pressure you will need to do your injection. So whilst we know that wider, longer cannulas give us some, we think we are safer with a wider bore cannula because you're less likely to enter a vessel. If you are already in a vessel, the bigger that cannula, the harder you have to push, the more devastating the final outcome. So you have to balance those risks, which is why I said needle and cannula is not the risk factor. The risk factor is where are you pushing that product? Where are you putting the needle or the cannula? In the right depth, away, and knowing your anatomy suddenly becomes incredibly important. So how are we going to reduce the risks of actually doing an anterograde emboli? Well, I've alluded to some of those. Feeling for pulses and looking for veins. We don't, as doctors, we know how to feel for a pulse. We feel for them on the feet, we feel for them on the wrist, we feel them, in the antecubital fossa, we feel for them in the neck. There are pulses all over your face, your superficial temporal, pulses up here when we're trying to avoid entry points for temporal treatments. There are pulses all over the face. And if you actually just start taking time to feel for them, you can map superficial arteries very easily on your face. Of course, you can't feel deep arteries. And if somebody has got a lot of parallel fat on their face, the fat precludes you feeling them. But then they're not on the surface. If you want to do a subdermal treatment, there's no pulsation. Wherever that artery is, it's deep to the muscle. If you put your product above the muscle, you're not going to hit the artery. So there are things that you can, just using your medical knowledge, thinking about what you're doing makes a difference. Following the direction of the vessel is the biggest risk factor, because you can then get carried away by the vessel, like I did with the vein. Going at 90 degrees to the vessel is actually the safest entry that you can do. Nowadays, of course, we have access to and the ability to use an ultrasound scanner to map arteries on a patient's face. Remember that using ultrasound requires skill. So if you're going to use this to map your face, you have to do it on every patient, get very good at it. Okay. Shorter, smaller needles require less pressure. They just do. So if you are one of my very good colleagues, Lee Walker, he does a lip technique using a 4mm needle, and for sure, less pressure, less discomfort to the patient, and the feeling of being a bit safer. But actually knowing where the depth of the vessel is far more important. If you know that the vessel is deep to the muscle, you can go superficial. If you know that the vessel is superficial to the muscle, you can go deep. The knowledge of the anatomy is actually key. Just, there's a really nice paper about cannulizing vessels that you may want to look at. So what happens? Let's say we've done all of that and we've still been phenomenally unlucky and we have a patient with visual loss. How are you going to document the loss of vision? A lot of people ask me, if I get visual loss, what will I do? How will I treat it? How much hyaluronidase should I put in? Where should I put it? And the truth is, before you start anything, you actually have to document the visual loss. If you start trying to do complex injections in and around the eye, and you haven't really even established if the patient has lost vision, right? You're already dropping down a rabbit hole that you cannot get out of. Remember, from a time perspective, it's instant. If you're injecting a patient and they say, "Oh my God, doctor, I can't see," it takes 5 seconds, literally, for the arterial blood to be blocked, to the visual cortex not being able to see that image. It's important you establish, first of all, if both eyes are affected or one eye is affected. So you stop, obviously, injecting, make a mental note of where you were injecting as you stop, because that point is going to become very important. If it was a cannula entry point, sometimes they're difficult to see when you take the cannula out. Make sure you just put a little white circle or a little mark that you know where you were when it happened. And then the first thing you have to establish, has the patient really lost their vision? Are they just feeling a bit faint? Because people go, "Oh, I can't see," because they're fainting. Is this actually a visual loss associated with the dermal filler, or are they just feeling unwell or a bit lightheaded? One eye or both eyes? And how easily can they answer that question? So if they say, "I can't see out of this eye," has this just happened? Have they just taken their glasses off? Has this just happened? Is the time frame correct? Actually, my eye was feeling a bit funny this morning, and now I feel like I can't see. It may not be anything you've done. You have to establish these facts and you have to document them. Sudden loss of vision within 3 seconds of an injection, just in one eye. Okay. That eye looks, can you see everything normally yet? Everything looks really blurred, or I can't see at all. You have to actually document their visual acuity. This is very important because historical cases of visual loss haven't done this. And then it's very difficult to establish whether we actually recovered any vision or not, because we don't know how bad it was immediately afterwards to see whether anything we did caused any improvement. Okay, because it might be that they had no vision at all and we got them back up to halfway down the chart, but they're still not fully down the chart, so they are still classed as a visual loss, even though they may have had some recovery by the things that we've done. Obviously, if they come to an eye casualty department, we measure all of these things, but you, for your own medical legal benefit, should document what the visual loss was. So most of you will not have a chart in your room, because that is not something that you would be likely to have in a skin clinic. So standing at about 1 meter in front of the patient, asking them if they can see enough to count fingers, 2 fingers, 1 finger, 3 fingers, and we do it at 1 meter. If they can't even see your fingers, you have to ask if they've got hand movements. Can you see my hand moving? Which way is it moving? No, yeah, something's moving that way, something's moving that way. Hand movements. If they don't even have hand movements, then we have to check if they've got any perception of light. So you need a torch, just a little pen torch, and say, can you see the light shining in their good eye? Can you see the light shining in their bad eye? And if they say, oh yeah, I can see some light, sometimes we can even go into, can you see it? Which direction is it coming from? Oh, it's coming from there, it's coming from there. Tells us that they've still got some perception of light. Or they might say, I can see it coming from there, but I can't see it coming from there. Tells you, gives you an idea of how much visual loss they've had. In ophthalmology circles, if someone has perception of light, we also do this thing called a swinging flashlight test. You might remember it from your medical student days, where you swing from one eye to another. Remember, light causes the pupil to constrict. And when you take the light away, the pupil dilates. And if you've got a slightly damaged nerve, but not a completely damaged nerve, they might have perception of light, and you can swing the light from one eye to the other. And what happens is the good eye can detect light coming in and the light leaving. The bad eye can detect the light coming, but when the light leaves, it doesn't see it quite so well. And over time, if you swing the light from one eye to the other, the good eye overrides the bad eye. So you get constriction in the good eye, constriction in the bad eye, constriction in the good eye, constriction in the bad eye, constriction in the good eye, dilation of the bad eye, even when you shine a light to it, because your brain perceives the light moving away from the good eye over the light being shone into the bad eye. And we call it a relative pupillary defect, because it happens when you swing relative to the good eye, that the nerve has had some damage. So these are tests that we can do very quickly. Can you see the light? Can you see the hands? Swing, 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 swing. Yeah, definitely this patient has had some sort of nerve damage almost instantly from compromise to the blood supply. You have to measure it, count fingers, hand movements, having the ability just to even see if their pupil is constricting. If you have an ophthalmoscope, we're all doctors, we're all taught how to use ophthalmoscopes, whether you still know how to do that. You can actually look in the eye, and you may even be able to see exactly where that blockage is. Because if you can visualize the retinal circulation, you will be able to visualize a blockage in the eye pretty easily. If more than 15 minutes have passed by the time you look with an ophthalmoscope, you might even see something called a cherry red spot. So cherry red spot is diagnostic of a retinal artery occlusion, because as soon as the blood supply is compromised, you get edema. You get edema of the retina, and it gives it a white, fluffy appearance. But the retina is very thin at the macula, so the choroidal vasculature, which is a different blood supply, is still pink. So you see the pink of the choroid over the white of the retina, and you get this red spot. Cherry red spot appears after about 15 to 20 minutes, quite quickly, and will stay for a good few hours. So it's not an immediate sign, but it is a sign that the vasculature is compromised. And if the cherry red spot improves, we know that we've regained retinal circulation. So being able to use an ophthalmoscope does help. You don't have to, but those of you that can should. So disaster has happened. Your primary goal your primary goal is to restore blood flow. That's your main thing. How do we restore blood flow? Well, we've got hyaluronic acid blocking an artery. What can we do to try and break up or minimize that effect? Well, we know that hyaluronidase has some effect in breaking down hyaluronic acid long chains. And it also improves, it actually makes the blood vessel porous to the extracellular area. So things that are in the blood seep out very quickly because it opens up the blood vessel to the surrounding area. It's like a drainage system. So it has two effects: the breaking up of the actual hyaluronic acid and the improvement that the blood vessel becomes leaky. It's particularly effective in veins. So that vascular effect that you saw, 2 injections of hyaluronidase and it just literally flattened out in front of my eyes. Okay. With so we need to try and get this hyaluronidase to the back of the eye. How are we going to do that? Well, your entry point got the hyaluronic acid there. Your same entry point should hopefully help you to get the hyaluronidase there. If you can reproduce your injection, if you can, that's going to be a 99% sure way of trying to reproduce what you did. So if you had a cannula in the face when it happened, if you even just unscrew your filler, suck out what the filler that's already there, because you want to keep going with it, or you can put in a fresh cannula that doesn't have any filler in it, in the same place that you had the original, and flush it through with a big bolus of hyaluronidase, chances are you're going to end up in the same place. That's one option. The other option, of course, is how do we get a shortcut to the back of the eye? Remember, I told you that there are some arteries that actually feed, you know, they're part of that internal carotid circulation. How do we get a shortcut? So I told you the arteries, dorsal, nasal, supratrochlear, supraorbital. The easiest one to access, easiest ones to access, are your supraorbital and your supratrochlear. And if you actually run your thumb or your finger along your orbital margin, you can actually feel your supraorbital notch very easily, just running along the top of your orbital margin. And in there, up under there, is your supraorbital artery. And if you draw up your hyaluronidase and stick a needle right in there and push hard, you've got a good chance of getting that shortest distance to your ophthalmic artery and to your central retinal artery. Under pressure, push hard, fast, because we want to overcome the systolic pressure, right? So you want biggish needle, shortest syringe, and 1 ml syringe, and bolus it in fast. Okay. Remember, if you actually do get a needle in an artery, when you take it away, it will bleed and bruise. You have to put 5 minutes of compression on there. Otherwise, they'll end up with a big hematoma on top of everything else. Remember, if in the days when we used to take arterial blood samples, I don't know if you're that old, we used to take radial arterial blood samples when we were doing oxygen levels.
Yes.
When you stick a needle in an artery, the pressure of the artery gives you backflow. You'll see it instantly. And we've only got a very liquid solution. You'll know when you're in the artery, you'll get backflow. You'll know. In you go. That's your first, quickest thing. Other things that we need to do to try and improve vision. We need to reduce the intraocular pressure. Remember, this is your eye is a closed system. It has internal pressure and there's external blood pressure. If the external blood pressure is greater than the internal eye pressure, blood flow will be better. Things that we can do to reduce intraocular pressure. Acetazolamide is something that we give as an oral tablet, often in eye casualty, to rapidly reduce intraocular pressure. You can give 500 milligrams. It's a very inexpensive medication if you want to keep it in stock in your clinic. You can also massage or block the eye. Just by doing this, softens the eye and reduces the intraocular pressure. It's something the patient can do while you're waiting for the ambulance. Low risk other interventions. What else could you do while you're waiting for the ambulance? Aspirin. So aspirin is an antiplatelet. In theory, would have no effect on hyaluronidase whatsoever, on hyaluronic acid. But platelets can make your blood sticky. So if you make your blood less sticky, maybe you will get improved blood flow. Giving 300 milligrams of aspirin, unless the person is a bleeding risk, it will have no serious side effects and might help. We're looking at things that might help. Rebreathing in a paper bag increases your PO2. Will it improve the oxygenation of the retina? Maybe. If it might keep the patient calm. Not having a paper bag on site is not the worst thing you can do. What should we not be doing? So there was a bit of a fashion for a while of doing retrobulbar injections of hyaluronidase. There is actually virtually no evidence for this, not least because your ophthalmic artery is wrapped around, or your optic nerve is wrapped around your ophthalmic artery. So if you're giving retrobulbar hyaluronidase, the chance of it actually getting to your ophthalmic artery are pretty slim. And if you don't know how to give a retrobulbar injection and you end up piercing somebody's eye, that is a risk probably not worth taking. Okay. If you've dealt with the visual loss or you've had an intra-arterial event that has not led to visual loss, there are things you can do to speed up the recovery of skin, which include red light therapy, hyperbaric oxygen, hyaluronidase. But these are things that we do for recovering skin if we're not talking about visual loss. So these are not things that you need to think about when you're doing visual loss. So people often talk about hyperbaric oxygen, but that's not part of your immediate treatment to get this person into hospital and get the hyaluronidase in. Hyaluronidase given after an event will help improve the collateral circulation. So of course we can give it to speed up skin recovery. But in your immediate visual loss, these are not things, obviously hyaluronidase is something that we do, but the adjunctive stuff is about after the event to speed up skin recovery. This is one of my patients. This is actually my best friend. And I did this to her. This is an cutaneous, some 12 odd years ago, long before we even knew or understood vascular events. This was a vascular event that happened to me. And it was a mistake because I did not know or understand the anatomy of the forehead well enough to be able to avoid it. So the depth of injection was incorrect. And she had a supratrochlear, as you can see, vascular event. But it was cutaneous because it was tiny quantities with a very small needle. She had no visual loss. She had no intervention to improve her. Skin has very good collateral circulation. So she actually got better on her own. Okay. To reassure you that skin necrosis, generally speaking, has good outcomes with relatively little intervention. What are you going to need in your clinic to get this right? Time is of the essence. Your window of opportunity to recover somebody's vision is under 2 hours. And the first hour is the most important time. The first 20 minutes are really important. Time. You need to be quick. You need to know what you're doing. Document the vision quickly. Just something as simple as having a pen torch. You know, an ophthalmoscope is fine, but there's no point in having an ophthalmoscope if you don't know how to use it. Don't invest in an ophthalmoscope if you don't know how to use it. But a pen torch is $2. You know, you can shine a light, see if their pupil is reacting. Your hand is free. Hand movements, fingers, document their vision. And we normally document it, whether we do it at 6 meters or at 1 meter, we document hand movements at 1 meter, counts fingers at 1 meter. Perception of light, no perception of light. Relative afferent pupillary defect, if you have time to test for it. This is your emergency kit. Take note of your emergency kit. Your most important thing is hyaluronidase. Most recent updates say don't mix with sodium chloride, mix with lidocaine, because lidocaine is a vasodilator. So as long as your patient is not allergic to lidocaine, mix with lidocaine, because you will get a vasodilating effect as well as the effect of the hyaluronidase, and it will decrease the pain of the injection. Remember, hyaluronidase comes as a powder. So you need a needle and syringe to mix it. It doesn't come in a pre-filled syringe. So you have to make sure you've got needles and syringes available to do the mix. I know it sounds very basic, but sometimes mobile practitioners, they just walk around with their box of filler and they have their medicines in their bag, but they don't have needles and syringes actually to mix it up if they need it. I know it sounds stupid, but these are things that have actually happened. Aspirin is easy to carry. The acetazolamide is easy to carry. Okay. Do we really need to worry about such rare events? I mean, in reality, how common is it? How common is it to lose vision from filler? It's very rare. But I don't know if you know who these two people are. Chesley Sullenberger, he's the man who landed the plane on the Hudson River. Remember, there's a plane that lost both engines in America, and he landed the plane on a river, and he rescued the whole of the plane. He was the last man off the plane, and they made a movie about him because he was a hero. Francesco Schettino was the captain of the Costa Concordia. The ship went onto some rocks. He did a very clever maneuver to try and save part of the ship, but he was one of the first people off the ship because he panicked, and 32 people died as a result of that disaster. These were both very experienced captains of their ship, just like we are experienced practitioners. And neither of them woke up that day thinking that what they were going to do on a day-to-day basis was going to have such a great impact. Chesley is a hero. Francesco Schettino is in prison, 16 years, 6 months for every person that died. Okay, it sounds like a very short sentence, but that's 16 years, very experienced captain. The difference between these two people is not how good they were. In the US, they have mandatory training for never events. Landing a plane on a river is a never event. Nobody ever lands a plane on a river, but they practice it on a simulator as part of their mandatory training. There is no mandatory training for captains of ships. Their experience is supposed to carry them. So if you want to be the best practitioner, you have to put that on yourself. You have to pretend, what am I going to do if somebody has a vascular event? Have I got my emergency kit ready? Who am I going to phone? Do I have a written? And you practice it, because the more you do it, the better you get at it. I've had 2 arterial events in my life. The first I was not very good at, the second I smashed it. I've had 2 venous events in my life. The first one, I was in such a mess, I cut my finger on the vial as I broke it open. So then not only was I trying to fix the patient, I was bleeding everywhere. Right? Second venous event, we videoed it. That lady with it, within 10 minutes, she was back to normal. We finished the treatment. Practice makes you do it. Don't practice on the day it happens. Practice before it happens. That's my top tip. How are we doing for time?
Dr. Tahera, we are a bit behind time.
Okay.
Yes, so I just want to comment on the two analogies, very, very good analogies indeed. And I think it's always good to be prepared for the worst case scenario and treat as if every case there's a possibility, hopefully not, but there's a possibility for an adverse event. I would still like to take some questions, particularly because this topic is quite an important topic. So let's just take two questions before we do a close, but we have some tips as we're about to close that Dr. Tahera will share with you with regards to the visual loss. She has some key tips at the end of the session, so please hold for it. So I'd like to take some of the questions. So first question is, how long is the golden period for visual disturbance?
For treatment or for diagnosing? You mean how long?
How long is the golden period for visual disturbance? I think once you diagnose,
if you've diagnosed it in hospital, we say 2 hours. If we recover the vision within 2 hours, we will probably get a reasonable visual recovery. If we can recover it in the first 50 minutes within the hour, we'll get almost a full visual recovery, because there is not enough time to get long-term damage to the retinal layer. If we get it within 20 minutes, you'll get full recovery. If you get it within the hour, you'll be okay. Then it starts to drop off very rapidly. 2 hours, really, if it's been more than 2 hours, what are the chances? Pretty slim. Time is so important. It's like if you've had a stroke, you know, we say you have to get the anti-stroke medicine in within 4 hours. Right.
Okay, so to that point, so 50 minutes is a really short time. So as soon as you diagnose, basically action needs to be taken. Okay, so
that's
next
why
question.
You have to, that's why you have to practice and be quick at it. You can't learn on the job.
Right. Okay, so next question is, can visual loss always happen directly after the injection, or it can happen even up to like 24 hours a day after the treatment?
Extremely unlikely that the emboli would take that long to get there. I can't think of a mechanism whereby the dermal filler would... Okay, I can think of a mechanism actually that you would get a delayed visual loss. It's a good question. Nobody's ever asked me that before. If it is an arterial emboli, it will be instant. If you've got a venous emboli, it will take longer, but I can't think of how your venous circulation from your face would end up in the back of your eye.
Okay.
So theoretically, yes. In practice, I think it's going to be a quick thing.
Okay, got it. So rarely it would happen 24 hours post treatment.
I can't think of a sensible way that it would be 24 hours later without any other symptoms. If it was just a visual loss, I have seen a vascular event where somebody had an injection on their lateral tear trough and the patient developed excruciating pain. So about 2 hours later, so we know it was an arterial event, but they actually got a venous effect on their conjunctiva. So they got a subconjunctival hemorrhage. So there was clearly some buildup of pressure that caused a vein to burst in their eye. So if you get a burst vein at the back of your eye, that will give you visual symptoms later, even though it was an arterial event. So still an arterial event, but with a backflow issue where you get a burst vein, which is what I observed on a patient about 3 months ago. I should have actually put the images of that. I've got photographs of that. I'll remember for the next update.
So, okay, last question that we'll take for tonight. How much hyaluronidase should one administer to the supraorbital notch? And entry point, I think you mentioned earlier. So I think how much is the dosage? And then when to stop the hyaluronidase and send the case to the ophthalmologist.
So you should somebody should be phoning the ambulance and arranging that immediately, because a specialist intervention at a hospital, if they know what they're doing, will give you the best possible outcome. In the meantime, drawing up hyaluronidase into a syringe should take you 2 to 3 minutes tops. So your ambulance is not going to be there within 2 to 3 minutes. So that is something you can do straight away. In the UK, the vials come as 1,500 units. In the US, they come as 150 units, but that 150 is actually the same as the UK 1,500. So as far as I understand, the dosages are pretty much universal. I know in some countries they use a non-medical version of hyaluronidase, like a mesotherapy type. Don't use that because we don't know how that works. Use medical hyaluronidase. You mix that whole 1,500 units, because right now you're not caring about whether the cosmetic outcome is going to be good or bad. You just want to get as much of that stuff in where you want it to go as quickly as possible. So I would mix the whole 1,500 units in 1 to 2 mils of lidocaine. I would do 1,500 units through your original entry point if you can, and I would also do 1,500 units into the arterial circulation, shortest route to the back of the eye.
Okay, got it. But I just want to, pop this question out there for discussion. So from, Teoxane's standpoint, I understand that usually the periocular area is strictly restricted to, eye surgeons or ophthalmologists only. So I just want to make a stance that we are not directly advocating for you to, if you're a aesthetic physician, or you do not have the qualification to, or not confident enough to directly do an entry point to the supraorbital notch or the supratrochlear. So I think it does take a high level of expertise. Dr. Tahera, do you have any comments for this?
I completely agree. We can't do harm. So if you don't know what you're doing, don't do it. But if you remember that most eye casualty departments will also not know how to treat a hyaluronic acid embolus. My heartfelt advice would be go with the patient to the eye casualty department. Get in the ambulance with them, drive them there yourself, take the hyaluronidase with you, explain it to the ophthalmologist and ask them to do it, because you will save their sight.
Okay. Great tip. Thank you, Dr. Tahera. So I know that you, Dr. Tahera, Dr. Henry, and Dr. Fong, you have some final tips for our participants today, but let's have the polls up right now so that you can, just go through. There are just about 3 to 5 questions. And then we would have Dr. Tahera to share her tips, and then we'll do a close and we'll share with you the date for our next webinar. Dr. Tahera, I think you need to stop sharing your screen.
I beg your pardon. I'm miles away.
If we can have the polls up. Okay, so we are having some technical issue with the poll, so sorry about that. Okay, so maybe we can have the next slide. Okay, so this is the date for our next webinar for this series of Behind Those Bright Eyes. We will focus mostly on complications, and we're so happy Dr. Tahera will be joining us again for this session. Dr. Tahera, do you have any closing words?
So I'm looking forward to doing complications because they span everything. And we just took this little standalone topic, which is visual loss, because I think it's quite relevant to the Asia area at the moment. There's a lot of talk about it. But actually, most of the complications that worry us are really to do with poor cosmetic outcome in this area. And we're going to talk to you about how you can handle all those, really, from a bit of swelling and bruising to a bit of lymphatic issues, to really horrible looking treatments that need to be reversed. So I'm looking forward to doing that with you.
Okay, so are we, and we're looking forward to hearing your tips on how to avoid the poor cosmetic outcomes and also other related complications. So what we did today was 2 fantastic case sharing from our country experts, Dr. Fong and Dr. Henry, as well as visual loss session lecture and the tips how to avoid and how to assess and how to manage when you done a dermal filler treatment and you're not sure if there's a visual loss. So may I have Dr. Henry to share with us some tips and then followed by Dr. Fong to share with us some tips before we close.
I think what I like about giving the lecture from Teoxane is the ATP. So the key is going back to the ATP and your master your anatomy, your technique, and of course select the best products in the market. So I think it will summarize all of the technical issue and also minimize our risk of the complication, hopefully.
Yeah, and I agree with Dr. Henry, and my tip is the like Dr. Tahera said before, I usually do the injection slowly, and I'm always do with the lower pressure and a small volume to reduce the complication. Yeah.
And
Okay,
my final tip to everybody is keep educating yourselves, right? You educate yourselves and then practice it. And, you know, if you keep coming on webinars, hands-on training, you know, you'll have the opportunity to contact the APAC events team if you want the hands-on training, because that's what brings you up that learning curve. Keep learning.
Yes, definitely. So thank you so much, everybody. And thank you all the participants for joining our webinar today. If you have any other further questions, please, you can DM us on Instagram. You can message us at Teoxane APAC events at teoxane.com. So we're looking forward to our next session. Goodbye, everybody.